Athletes, take your mark, get set. It's time for the Addict II Athlete podcast. Everybody out there, Coach Blu here. I want to give everyone a special shout out and thanks for downloading, subscribing, and sharing this podcast. We really are grateful to have you guys share this with people that may be struggling with any kind of addiction. We found that our erase and replace philosophy, it holds true to no matter what addictions you might be battling. And even for the folks that want to support or know or love someone that's battling addiction. Athletes, I want to turn your attention to our website, addict2athlete.org, for lots of content, lots of amazing stuff to help get some answers to questions you might have. And it is because of that process, I am excited to have a guy that Marissa, the athletic director, found, believe it or not, on TikTok. And after doing a deep dive on Dr. B here, I'm excited to have him here because he is a titan in the industry, I'll say. Dr. B is the founder, director, CEO, and medical director of the American Addiction Institute, and that's a nonprofit IOP program for substance use and mental health. And so, Dr. B, before we jump into this, thank you so much for coming. Like I said, it's an honor to speak to you. I know you're incredibly busy and under the weather, so thanks for carving out a little bit of time. But would you mind introducing yourself to the listeners, a little bit about you? I'd love to know a little bit about why you moved from emergency ER medicine into the world of addiction recovery, because I think that's quite a leap. You must have seen some amazing things to make that transition.
Yeah, well, first of all, thanks for having me. The pleasure is all mine. And I'm sorry I'm a little under the weather and I was late today. And again, thank you so much for having me. Sure, I think that's a good place to start. I'll give you a little background. Historically, I'm not a businessman or have anything of my own. I've always been in academic medicine, right? My background is academic medicine, in particular emergency medicine, and with that comes trauma, critical care, pediatrics, toxicology, a lot of stuff. And I trained and was eventually recruited at UCLA offsite, UCLA Kern, and then eventually UC Irvine. But in that capacity, that was a wonderful job. I loved it, both the training and we were really well respected in our small world of academic emergency medicine. I remember a guy from USC who are like the kings of this said, hey, you have two choices. You can either train in emergency medicine during the war in Lebanon in 1982, or you can go to Kern and train with those guys. And I was those guys at one point. That's a county facility, actually, and I love that kind of spectrum of patients. You get great pathology, and you can really do a lot of service for a marginalized set of population. Kern County is one of the poorest, least educated counties in California, and a few years running, it made the list as the least educated city, Bakersfield, in America.
Oh man,
it's a real show there. In that capacity, I've always had a very, very keen interest on serving marginalized populations, and I've had a particular interest in our field. It's toxicology, which falls into overdoses, heroin, substance abuse, all that stuff, which is right under the flagship of emergency medicine, and we were. Two things I started to notice was one, addicts, heroin addicts, when they came in, and let's say I remember one case in particular, and I talk about this on an interview with Andrew something, the YouTube channel's LAHWF.
Right.
He does a 2-hour interview with me, and I describe some of this. One of the things I keenly remember is a guy had come in, and he was muscling it in his left shoulder. I still have pictures of this for teaching. And he had come in, and he had what's called the necrotizing fasciitis, which means everything just gets eaten away. And they had done a skin graft, and he was so underdosed with pain medications, he had just bounced. Now he had come in, and his left shoulder was black, falling off down to the bone. And I was going to readmit him to the surgical service. And they're sitting here trying to put this guy on 2 milligrams of morphine an hour. And I'm going, this guy's a heroin addict. On top of that, a normal person would need at least 4 milligrams an hour to deal with this. And that really struck me.
Yeah.
In addition, we were sort of the kings of overdoses. Someone overdoses and they come back and we do the Narcan and reverse them. Out in the field, what happens is, and the paramedics were great. Out in the field, what happens is you immediately get 2 milligrams of Narcan because they want to give this huge dose to get you breathing again. And there's a lot of logistics. They just go. What happens with that huge dose is you go into precipitated withdrawals the minute you wake up. Right?
Like instantly, right? Like right now.
Yeah, it's painful. Now, they would get to the ER and they are in bad shape from the precipitated withdrawals. They couldn't care less about the overdose. And I didn't like sort of the attitude towards that of whoever. And these are great people. But again, it's they've been kind of shaded by experience and being in the trenches and dealing with this stuff. But the attitude, you don't have that attitude towards a diabetic in a situation or someone with heart failure. Well, this guy's going, and the attitude, I wasn't. So, one of the things I would do when you could still do that is give the guy 10 milligrams of morphine and then watch him for 1 to 2 days. A lot of these issues, and then when I made the lateral transition to the university in Orange County, I realized that, my whole life I've really not been a corporate guy, and even academic medicine is turning into corporate medicine. And the sort of hardcore clinical position that I've always sought after in academic medicine was sort of disappearing, and that's another discussion.
Oh, yeah.
Yeah. And I was becoming better and better at managing mainly the heroin addicts. These guys, I was buddies with them all. They'd come in, I trained their bellies from the hepatitis C, give them a little bit of a shot here to get them going. And I just one day realized that I didn't want to do this academic medicine thing anymore, even though it was good money, good price, good pay. I enjoy the research, I enjoy my colleagues, but it just wasn't going to do it for me. And then I also noticed how I thought the care for substance abuse within all the private facilities in Orange County were just way off the mark. There was no science and there was no compassion. And then number two, the insurance mix up because there's so much money involved.
Right.
The insurance people trying to make as little days as possible. You have these guys. And I looked at the whole thing and worked for a couple of places. And for me at that time, this is only 4 years ago, I was like, this is cool and this is bombastic. These people need what we call evidence-based scientific care, professionalism, and compassion. And in my mind, I was like, I can do this better than all of them. And none of them know what the concept of harm reduction is. And that's how I made that insane leap, and I'm still surviving.
Well, when you take that path to say, hey, 4 years ago, I mean, that's still fairly recent. I'm sure you were probably getting the side eyes and kind of like what do you think you're doing? This is the way it's always been done. But you're like, no, there's got to be a more excellent way to do this. And I'm seeing things that aren't working. I love the fact that you're identifying the same things that we've seen in the treatment world, where it's it was almost like pulling teeth trying to get qualified medical personnel to come in and to not just listen to the addict, but to know the addiction. And I think what you're doing is amazing, because you're not taking it as a blanket covering of everything and one size fits all. You're opening into the horizons to many modalities of like MAT, of the individual person seeking recovery in and of itself. Did you get some pushback when you first started kind of detaching yourself and started creating a different mentality? I mean, harm reduction 4 years ago, they would have ran you out. I can only imagine, because it was abstinence or nothing. And if it was a medicated thing, it was, it was very monitored. It was a rapid detox, and to get them off it and taper them down real quick and then get them back out. Have you noticed the change over the years from rapid tapering for people that really need MAT to like long-term? Because I still think there's a big stigma around that. I think I still see treatment centers that I've worked for and since left that have said, no, they're in here. We're going to get them on Suboxone. We're going to taper them down as fast as we can. Then we're going to get them moving, because that's what we know should work. But it doesn't, does it?
No, it doesn't. So as far as the pushback, not only did I get it then, it's still there. And it's even there from the patient's perspective. So a lot of them that have been, I look at the insurance cards as a gold MasterCard because it becomes a lifestyle for some of these guys to go treatment hopping. And it becomes a cultural expression versus a treatment expression.
Spot on.
And that's how I describe it. I can go to Costa Mesa and sit in a coffee shop and pick each one of the kids in rehab, right? It's, the way they wear their hats, they all go to the same gym. They're just hopping. And to the extent, there's been some movement, but to the extent a lot of these guys play ball, it's simply because some of the insurance companies are like, look, what you're doing isn't working, so they pretend. So that stigma is there. The lack of knowledge and understanding is still there. And it's all around, whether it's the physicians, the patients, the treatment providers, and society at large, including the parents. And when I went to do this, let me tell you, I have no interest in being a businessman. I don't want to starve and die.
Here.
My interest is a paradigm shift, and I'll start with one person at a time.
Yes.
I want nothing less than a paradigm shift. If I want to be a businessman or make money, I can. Let me tell you, it's been a struggle. And if I knew anything about business, I'd be a very rich man even by now, because we do good work. I treat guys as an outpatient through the office and you can validate this by talking to some of them or coming in, that have been to 30 treatment centers at a cost of over $1 million. Right? I have many guys like this, right? And nothing I do is genius. This is the great thing.
Yeah.
I take credit for being a progressive innovator. And sometimes some of the guys that really know say, hey, Dr. B, they don't get that nothing you're doing is groundbreaking. You want to know what I do? I read. This disease is a chronic disease model, which you can get the best response approaching it that way. Your doctor should be the same doctor. You shouldn't have 50 different guys writing different medications, because the same guy is going to get to know you over time, understand your physiology, your mental health, your social issues, your legal issues, and really work with you over time to get this thing under control. I mean, I can go on and on about each one of these topics. So because the resistance is still there. Some people pretend it's not. And the lack of education from the provider side. For example, I am extremely good at micromanaging my Suboxone dose to deal with sleep, anxiety, depression, beyond withdrawals, and the science backs me up. Very few people take the time to do that or get to know that medication.
Yes.
I hope that answers some of the.
Well, it does. And what you just said there, I think kind of like sums it up for me too, Dr. B. And that's the time. Who really invests the time? Because, it's interesting. I love hearing what you're saying, because it's what we do on Team Addict II Athlete. It's a free community resource, much like what a 12-step would be, only we're not 12-step at all. We're very not anonymous, and we're very much, in the public eye, and we do things to help people understand that once an addict, always an addict isn't true. And the interesting thing I've noticed is that we have people that have been around since we started year one. That was 10 years ago. And it's about the time. Do you see that being a problem even in today's treatment world, where it's all about getting that next bed filled? And so it's a rapid process instead of the time that it takes, because the money's not there for it, but that's a real person that's sitting on the other side of that office, right?
Yeah, and you nailed it. And so you nailed one area of it. So that time we go back to the concept of chronic disease, where you need to invest and they need to invest over a long period. What's interesting is everybody loses when you do the wham, bam, thank you, ma'am treatment. The patient loses, the insurance company loses, and society and families lose, because you need to, when a patient comes in, I tell them, listen, I am not a prescription monkey. I'm a physician and a clinician, okay? Giving you that prescription, as important as it is for me, because that's what I know from my training, that is one piece of my arsenal. Get that straight. Otherwise, we don't have a relationship. Now let's start building on, let's take that and build on all of it. Here's the problem with what it is that there's no payment for this long-term care. You know, it's really,
Right.
really, you know, we get paid oftentimes at pennies on the dollar, and it's tough, and we're trying to work that out. Where, you know, hopefully some of these guys with real insurances, you know, get more attracted to us and understand that this is not about what they want, and they shouldn't be dictating their care. If they want to get better, let's do this over the long term. Some of my patients, I mean, again, I think it'd be really cool. You know, some of these guys I've been taking care of 2 years, 3 years, 4 years, and days going through my system. I'm like, hey, you see that kid you just spoke to? I'm like, yeah. They're like, yeah. I'm like, 2 years ago, you wouldn't recognize him. He was abscessed out from head to toe and homeless. And they're like, you're kidding me, him? I'm like, yeah. And he had been to about 7 treatment centers. And that is what my private practice looks like, of guys that are basically, they come in, in best case scenario, they come in once a month or once every 2 months and just get their medication. And they know there's no need to lie about anything. And as soon as things start going south, they just talk to me and we get it back on. That's chronic disease at its most wonderful end stage, sort of tailored care, where they get to a point where it's just touch and go, get your medication. And so, yes, I agree with you when the payments aren't there up front. I mean, we put, I mean, you wouldn't believe some of these guys. I mean, everybody's like, you should be dead, you should be dead, you should be dead. And they're not even recognizable.
You know, to me, that is absolutely, to me, it's magic. And I think that with some of the turns of the tide that I like seeing is the more accessibility of MAT. And this was a big thing. I remember I worked for a government program for many years, and it was the same thing. I remember the switch from like complete abstinence to MAT, and then trying to change people's perspectives. I remember some of my clients would come in and say, well, my 12-step meeting is upset with me because I'm taking this, and we had to, you know, untwine all that garbage. But the thing that's interesting now is that there still seems to be that little bit of a delay in like, it's going to work. I've seen so many folks that I've worked with personally that have like wanted to quit cold turkey, but needed MAT, but didn't want it yet. They would go out and grab, you know, whatever substance. What do you think that disconnect from, you know, something that's prescribed that can be taken as you give them, you know, to like help lessen the you know, the triggers, the cravings, all that stuff, versus them trying to go cold turkey? What are the people that are on the fence? What do they need to know about why MAT is so important, and that it does work if you follow your doctor's direction? Yeah,
some of the common things you know. Again, this comes from an old paradigm, much of it 12-step. Some of it, I'll tell you, quite a bit of it goes back to the Harrison Drug Act of 1914 and the first, before DEA, Department of Narcotics, I think it was, 1930, what they did to stigmatize addicts and addiction. The addict, until they feel I'm going to say safe and loved and not judged, until they feel that about these medications, which means we have to reorient everybody and educate them. Right. MAT is not addiction. It doesn't even fit the definition. Okay. They all have to get over that. So this constant trying, people have to get used. There has to, we have this in many areas of our society today, but it's a, you know, it's a cognitive dissonance from reality. Look, you have a disease, and again, please take that with a grain of salt. We're going to use the disease model to the extent. That's another thing I want to say. I want to touch base on that. I have a few questions about that, so thank you. Yeah, continue. Yeah, when I say let's use the chronic disease model, this is not what in philosophy they call an ontological status. And what do I mean by that? What I mean by that, it's not is. you do not have a disease, and that can be, yeah. Joe, look at it this way. It's a model that describes the situation, and I get results using that model, and I can predict outcomes using that model. Besides that, you're Joe, and you're not an addict.
Yeah.
You're Joe that has a problem, just like someone has diabetes, just like someone has heart failure, but it doesn't mean anything, and it shouldn't define you. And using this medication doesn't make you an addict, substituting one thing from another, because the definition they use when they do that is wrong. Let's get you to a place where we can deal first with the physical, then with the complexity of this disease at the physiological or pathophysiological level. Then let's move on to the mental health. Then let's move on how we can place you back into this complex social network and milieu, which in my opinion promotes the disease, and have it so you can have the best life possible as Joe. And I really want to be clear about that. I am a physician, so I can use this model. I've done my studies, it works. And then from there, we move on. This is a very complex situation that I can define in psychological, social, psychosocial, and political terms and say it's a disease of our society. So I just want to be clear on that. I use that model to the extent I need to get you well. Then let's move on, Joe. Your name is Joe, and you have this issue like I use a cane.
Dr. B, I love that so much. You've literally just answered so many questions. The things that I've tried to help my clients with too is to understand that the disease model works to a point, but that's the thing. I think I'm curious. What is your genuine thought on classifying it all just as a disease? Because I think I heard you correctly. It works to a certain point, but if we classify all this as a disease, then doesn't that kind of mean to the person who's going through it that there's no end?
Right. That's a great thing.
I have a really big question for you. I know you want to answer that one, but I was thinking, I teach, and I can only do this from personal experience. I'm 25 years clean and all that stuff, erase and replace. But I'm a firm believer that when the right principles are applied, when the right people have intervened and assisted, medical, mental, all that stuff, that you don't have to continually for the rest of your life be in recovery, but you can heal from this. What do you think of that? Healing versus recovery? I'm curious.
It's such a great question with so many nuances. And we can talk about just this.
I would love to know, because I'll be honest with you, Doc. I want to know because I do talk a lot about the healing of addiction and not being in recovery. I kind of tell my clients from now and then, I'm like, if you break a bone in your backyard or you're playing football in high school and you can't play football anymore, but then years later you're married and you have your kid and your kid wants to go out in the backyard and throw the ball to you, but you're like sorry, kid, I can't. I'm still in recovery from a broken arm. I think that when the right things applied and when the right interventions are met, that you can heal from this. I'd love to know your thoughts on this, Doc.
Yeah, that's so I have to be really careful when I talk about a chronic disease, and I want everyone to understand. I don't mean it in the 12-step way. I'm an addict for life, or have 30 years. I do not mean it in that way.
Thank you.
It's a chronic disease, but I mean it initially and for as long as I need to, and when I need to, when there is use, okay? And then from that point, we can move. And I jump from model to model, because now I ask, well, what are the underlying psychological issues that cause disease? Because I truly believe that, and the science kind of tells me that's the case.
Right.
And I move to that. And then from there, to the extent that I can, this is also a social disease, because there's a lot of malignancy within our social, political economy and structure. And then I try to get you back into a society, because I'll give you one example. As a kid, and I can say his name because he's all over the papers. They did a thing a few years ago in Orange County. His name is Brody Webster. And one day I was sitting there with Brody. Brody had been to 35 detoxes, and it took me 3 or 4 times to get him in. 21 years old, methamphetamines, benzos, heroin, marijuana. and he kept taking an Uber to come to me, and kept not making it there because he was in psychosis. Well, 3 years later, I just got off the phone with him. He's up in Seattle, and again, he's in the paper, so I can say his name. He's doing amazing. Finally moved back home, and he's not even the same person. And I remember sitting there one day, okay, what am I supposed to tell Brody once I get to where I need to? Go back to your shitty environment and get a crappy job at 7-Eleven and deal with all the crap throughout your childhood that you dealt with before and that ended you up in the same place. I can't say that to this. I have to give him the tools to go back into society, which I don't think is optimal, and cope and have a stress response that understands why he got to this place in the first place and deal with it so he can have as healthy a life as possible. And so I've moved from the physiological now to the psychological and social. And it is not an issue of you have this disease and that's it for life. We all suffer from the disease of addiction. And what do I mean by that? There's an emptiness and a need in every one of us for meaning, for a sense of self-worth, for our ego, the psychoanalytic ego, to be worth something, for connectedness with human beings. And many of these guys are missing that. Find meaning in yourself, not what society, your peers, or everyone else wants you to be. If I can get them to that, I will have gotten to the root of addiction. And we're no longer talking about you have this chronic disease addiction. And no, we're talking about the pathophysiology and malignancy of a social order that's gone down the tubes. Financial, economic, relationships, jobs, future. And so I hope that makes sense. I'm trying to put it all into a couple of seconds. I want these guys to find meaning eventually in who they are. And, this explains their anxiety, their depression, the complex post-traumatic stuff. And again, I'm just a physician, and I'm stepping outside of my field as I discuss these things. But I know for a fact that the data is clear, and I have to work to create a better society for everybody. And I can start with these guys who need it the most, and hopefully it spreads.
Yeah. Well, I like that. And for the longest time, the last several years, as you know, in the industry, when they started to bring addiction into the mental health world and try and combine the two, what are your thoughts on doing that? Is it a good thing that we've combined the two? Should we have always kind of kept them separate the way we treat things? Because at first I thought, well, this is going to be really hard. But then I started noticing that there's benefits when therapists speak with doctors and therapists and psychologists and the team gets bigger. But I've also noticed in places I've worked at that have not been so hot, there's always us versus them. And I think that's the dumbest pissing match to get involved in because it ends up hurting the client. Do you think that bringing those two things together was beneficial when they started to do that? Because then, of course, on my side, we used to own a treatment center and got out of that industry because it was very not good for what we were seeing, and we left. We started our own thing. What I noticed is that we would have to, as a therapist, we'd have to overemphasize issues because it didn't fit the medical model anymore. So I think, and I don't know how you feel about this, but it seems to me like the traditional treatment mentality, treatment model that we have now, that seems to be a dinosaur. And I think it's probably going the way of the tar pits. I don't think it's going to be around anymore because of what I've noticed in the industry itself. Do you see this going more medical long-term than it is traditional residential treatment centers, doing all the education, all the therapy, and then the aftercare, so, sober living? Or do you see it being more turned into like the medical model itself, where detox and then outpatient and so on? So I'm curious what you're seeing on the horizon.
I am, on a positive thing, I am seeing more push towards, in a way, the fact that this is a medical model clinical thing. So That's sort of positive. Nevertheless, I still expect it to go wrong because we are a reactionary society based on financial results. Okay.
Mm-hmm.
Turning it into one of the problems with purely turning it into a medical model based on medication assisted treatment is that is a reductionist view of disease. That means I take the manifestation of the disease, let's say in this case drugs, and then forget how it got there or why it got there. If it's anything more complex than a series of events that I can point out to with an x-ray or lab result or outcome. Having said that it's positive, hopefully it doesn't throw out the mental health. And the mental health, like what I've done in my program, and it took me forever to get someone like this. I have Dr. G, who's a clinical psychologist. We work hand in hand.
Beautiful.
Both I do my best, even though again we're having logistical issues as we grow. We both understand that initially I have a really good keen sense on how to manage these people playing with my medication. He starts on his therapy immediately. He understands the psychological as well as the greater social influences, including family, jobs, and greater society. So we're both on the same page. Beautiful. And our challenge is to get this thing going and be able to serve all the people coming in and train others, because we really see it in terms of harm reduction, greater model. So ideally, the doctor should not be in any kind of dissonance with the mental health team, with the case managers, with the social workers. Everybody should be on the same page, because everything is a trigger and a stress for that person to fail. And we should all work together and communicate. We're trying to get there. I admit we're a little bit failing just because of logistics, and we're trying to get everything happening. We need more people, we need more money to grow and do it that way. But our dream is to have this sort of holistic team. One thing that's amazing about our team is everybody really cares. Okay? Yes. Now it comes to getting everybody trained and communicate and document things like that. But so that's my view, is that hopefully, I think the medical model will take hold more and more, but that has its negatives, because we take things to a silly extreme, and we cannot forget, you give these people meaning, jobs, comfort, loved ones, get them out of the prison industrial complex. They're going to do well and flourish. And so, I think the whole model needs to be there. There needs to be very active communication with all team members, and these people can get there.
I love that. And that's the marriage and the union. I think that would definitely change the whole perspective on how to help someone, move from A to B. I mean, that would be the ultimate. And I love your vision. So with Team Addict II Athlete, it's a free community group, and we help people erase addiction by replacing it with things of greater value, not just, health and wellness and recreation. We do service and relationship building and all kinds of other things. And I've noticed that being plugged in has been good. But because we were working with the adult addicts, our meetings are completely different than anything else. There's not a lot of smoking and coffee drinking, because after our meeting, we go out and run or go out and work out or go play ball or something, hiking. We noticed there's a lot of younger kids that started to come, the kids of the people that are struggling with addiction. And some of them came with their addictions their own. Peeling back the layer on some of the youth treatment out there, I'm curious, because mostly what happens when kids get into addictions and whatnot younger, it seems that they kind of move towards like medications for moods and depressions and things of that nature. I had a question not too long ago by a client who asked me specifically, her son's been drinking. Would antabuse be a good thing for him? And I thought, I don't know much about that. And so I had her go talk to her physician, but it did raise a question with me. How prone are we to open up some of these doors for younger people? Has it been explored? What is I would imagine there'd be maybe some differences, obviously.
In terms of treatment?
Yeah, treatment, and even to a certain degree, if needs be, medicated assisted therapy. There's been like 16, 17, 18-year-olds that I've worked with in the past that have had severe addictions. And it's never really been brought up, and I've never even thought about it until speaking with you. And I'm sure the research probably, I don't know if it's out there or not, but like, is this something that you want to shy away from and do more psycho ed and therapy before you try that?
No. In fact, they actually suffer more than most because their hands are tied and they often get caught up in the system and what adults do. And in fact, everything I said applies to them even more. You have an opportunity to catch them before they fall super hard. Now, but getting to them has more liability and you need more resources. Okay?
Right.
I run the different program, which we just started. It's called Project Sanctuary. We took off the name of Sober Living Home and we call it evidence-based reentry housing, right?
Beautiful.
And because, in terms of how, and we deal with a lot of parolees, ex-cons, stuff like that.
Right.
It's the same thing. These people need, and the youth, they need resources. They need good mental health. They need love. They need to be empowered and have a sense of meaning in who they are. And most importantly, I'm a big fan of education because education empowers and gives you true choice instead of living in la la land and a mystery. So these kids need it most. And in fact, you brought something up about, I'm going to curb another concept. When I use the term medication-assisted treatment, I'm strictly discussing medication for opiates. Now you brought up the issue of psychotropics. Another problem. I have noticed, as far as I'm concerned, most people are over-medicated on the wrong medication. Remember, I'm a big fan of medicines because I'm a doctor, right? But I'm going to tell you, 8 out of 10 people on the medication they're on probably shouldn't be on it, or they're on too high of a dose. Medication-assisted treatment. These kids are being medicated and getting introduced to a concept that I'm absolutely against. I'm a doctor, not a prescription monkey. Let me solve everything else. Yes, I have people on medications, but and this was another area that sort of developed my practice. And some things are happening now. I have people that come to me for what would be called polypharmacy. I'll give you one example. There's quite a few of them. A lady in her now 60s came to me about 3 years ago when I started all of this, 4 years ago. She was on 17 different medications, psychotropics, dilaudid, benzos. She had the label of bipolar. It was endless. And I'm like, this is insane.
Yeah.
What I do is I spend as long as I need to and make my choices and do it a certain way, get them off of everything, and you see a human being. So 4 years later, she's on one medication and you wouldn't even recognize her. And I have quite a few of these guys. So those kids are falling into the same situation. Hey, kid, your problem is not for me to give you 500 of Seroquel a day. You're 15 years old.
Yeah.
Get to the root of the issue. Gangbanging is not where you need to be at. Let me tell you why. Let me get you to trust me and my team. We're not going to let you down. We're not going to enable you. We will empower you. We are going to hold you accountable and responsible. We're not going to judge you. Okay? And it starts to sink in. So that group needs it even more than the adult group. And parents need to be educated. Families need to be educated. Look, as far as I'm concerned, the whole society needs to be educated about what we need to do. Think about it. People, I hate it when I get comments, and I'll stop after this. I'm a drug.
You're fine.
And I'm like, dude, you don't know. This is the most insulting thing you could say to me. I speak out against pharmaceuticals all the time. When I was working as a attending professor, I wouldn't even let the pharmaceuticals come and buy breakfast for my residents. I would say, you guys will get enough. I was hated for that. And even now, I will simply say, think about what a pharmaceutical is. We live in a society where it's purely based on flow of capital. So if you're a pharmaceutical company and you make a drug and your livelihood depends on it, there's nothing else for you to do but push that drug on as many people as possible for as long as possible. How could that be a good, positive thing? It's just the nature of that economic exchange. And then we have insurance companies. Well, you're going to try and pay as little as possible for as shortest time as possible. How is that work in a social thing like health?
Yeah, you're right. It doesn't work at all. And that's the competing thing. And that's, phase two of that question then too comes when, here in Utah, we've just barely passed the Medical Cannabis Act to where people can get THC for medical purposes. I was kind of poking around in an outpatient program, and there was a doctor there that was prescribing it. And when the girl received her prescription, man, she started cheering like as if she just watched a touchdown of a football game she was rooting for. I got thinking, okay, we got to be super careful with this too, because I'm curious, as I kind of am teaching some of my clients and stuff, that now that THC could be available for that in Utah, very first year they've ever done this, that doesn't mean that if you're in recovery, you should run out there and get it, because I've noticed now several of my athletes and my clients have slipped back into active addiction because they thought, well, now I can use it. Well, I'm so curious of your take on this. Should people in addictions be now substituting, going back on that for the purpose of depression?
Wow, you opened another can of. Absolutely not. Look,
Thank you.
From the Bay Area, Berkeley, San Francisco. Traditionally, I couldn't care less if my own kid was smoking a joint at one point. And then I started to realize, wait a minute. And it took me a minute. Then I would listen to American Society of Addiction Medicine pound on marijuana, and I would listen to their lectures. I'm like, these guys are just saying that. They're a bunch of doctors in white coats and white collar folks. There's no science against marijuana. Then I start, and I do believe they were wrong and they were just saying it. And I'm like, yeah, okay, whatever. And then I started to notice something. Everybody in my program, I couldn't get them to smoke pot. They were abusing it, and they would not move forward in their recovery. This stuff, something's off. Then I'm like, wow, Faried, you're an idiot. This ain't the same pot as before. We don't know anything about this stuff, how powerful it is, the way people are taking it in. Then I listened to a lecture from a colleague at UCSF, and boy, people are going in for psychosis, anxiety, rehab, bad side effects. And then I noticed I really put my foot down on the marijuana. Anybody who did put that stuff away, their recovery went like this. It is an same thing. I don't care, marijuana or a pill. That stuff is prone to the market forces as well. They're going to push it on everybody, and we don't know enough about it. Absolutely, you nailed it. And I think it's irresponsible to prescribe that. In fact, if you are in my IOP or sober living home, you cannot smoke pot. I let the guys in my outpatient get away with it, and I work little by little. I mean, they're like, yeah, I continue to have anxiety. Hey, Joe, listen, I'm telling you, get rid of the pot, the anxiety. There's not one person who followed that direction and things did not resolve. Anxiety or getting on with their life. So I agree. You nailed it.
Thank you. Well, because I was wondering, and I'll tell you, because as I raised my hand of concern, it was, given to me back from the owner of the program that, well, this is harm reduction. And I'm like, I don't think this classifies as harm reduction. I'm sorry. Does it make sense? I mean, how could it be when now we're seeing that it's not just testing THC, but now it's testing alcohol, and now it's testing, heroin, opiates again. How is this harm reduction? So they shouldn't really use that as an umbrella of like, yeah, we can give this to them because at least they're not shooting heroin now. I'm like, well, it's not the same thing.
Right? Exactly. Here's what your response can be. People keep talking about Suboxone replacing one drug for another. Wrong. It doesn't fit the criteria of the addiction. But now they're talking about smoking pot as harm reduction. Are you kidding me? That's replacing one drug for another that will eventually be the way it is now with this cohort of patients, not regular human beings that don't have addiction as a issue, but this group of human beings, it will probably lead back into heroin. So it's not harm reduction. You're a short time replacing one thing for another that's going to escalate and snowball, and there's no science for you to. By the way, harm reduction is well embedded in scientific literature and results. When I talk about harm reduction and a methadone clinic, by the way, I also run a methadone clinic. When I talk about harm reduction, needle exchange, I'm not saying that, hey, let's just be sweet to people and everyone deserves to be nice to. I'm saying, no, this stuff, we got 50 years of data that shows that this is the way to go. So that's another thing. When they're saying harm reduction, where's your data? And what do you think harm reduction means?
Right. Yeah. And that's the thing too, right? And I'll be honest with you, Dr. B, when I'm driving around and I see the old yard political signs, stuck in the ground that actually say, hey, you need your medical marijuana card, call this. I think that's a weird way to advertise a medication, right? I mean, you wouldn't say, hey, if you need opiates, come here. It's just curious why people don't realize that. And maybe it's just because it's so new here, but I can see it being a very deep chasm if we don't get real educated on what it should be used for and if it should be used at all. So I just think that's very weird marketing. It's like you said, there's money coming in somewhere. So the same thing, I listened to your stuff on Kratom when you were talking to the gentleman from that society, and I loved everything you said, because for so many people, they're not seeing the other side, that they see the people that are really struggling with this stuff. Because as far as I'm concerned, Kratom, every time I've seen someone on that stuff, it's been a nightmare for these poor people. Same thing. We were told ages ago that when gabapentin first came out, it was non-addictive, and we were told it was non-addictive. And so my clients would come back in and they'd have, oh, my roommate stole my 90-day prescription of gabapentin. So the doctor would prescribe more, and lo and behold, another week would go by, he did it again. My roommate stole no, you didn't. You're using it all. So, I mean, we got to be cautious on this too. Like with the people in recovery, you have to know that if you truly want to get to that sober point in life, you've got to be honest with yourself, correct? I mean, we'll help you get there, but you got to do it.
You have an amazing insight, because most people don't get this. Look, gabapentin, I've never prescribed it. And in fact, I don't know if you've seen my videos. If you come into my clinic or program on GABA, you will get tapered off and you will be educated. Long before I made a video like 4 years ago, I think.
I'll find it.
I'll find it somewhere. And I said, look, gabapentin is a substance of abuse in the addiction community, period. And they're like looking at, and I was in that school for about a month, and they're looking at me like I'm insane. You nailed it on Kratom. Does Kratom have a therapeutic benefit? It probably does, from what I can tell. Not like this, right? And you're catching all this stuff that is the bane of my existence.
Yeah.
And so if we could put it all into all the stuff you're saying, what is the issue here? And for me, the way I see it, I think the issue is our political economy and infrastructure of how things work in this in our society, and how people make their money. There's no conspiracy. It's just the way we have things set up, right?
Right.
And so with that comes, let's not educate, let's miseducate. And because, TikTok is a wonderful platform, as it turned out for me, because working on people, but I can't educate you in a 30-second still.
No, absolutely. Yeah, well, that stuff that you did with the gentleman on the Kratom just recently, I listened to everything, and it was awesome because I figured it out. And you were great about saying, well, you're doing too much, and it's quick talkers. It's trying to dump as much information as possible, so that we ourselves say, well, this person has so much knowledge on this. Maybe I'm wrong. And I love that you didn't go there with them. And I thought that was awesome because that happens so much. Either it's with, a counselor and an addict, or it's a doctor and an addict, and they're trying to get them in and out. It's like, when you start dumping that much on people, they can do nothing but agree, because obviously you're the professional. So I really appreciated the way that you slowed it down, even though he really wanted to move you. And I was like,
you saw that, huh? Yeah. Yeah. So, wow, you caught all of that too. What happened is, Max, I'm sure a great guy. He was actually a policymaker, senior policymaker in the Reagan administration. When I went in there, I had no idea who he is. And he had sent me some things about his positions. I'm like, okay, great. The only thing I want to talk about is Kratom. And he started to use these techniques, which I would watch on Fox News or something.
Yeah.
I'm not going to go there. No one's cutting me. I'm going to stop right there and say, number one, the stuff you're saying is meaningless.
Yeah.
And, and so I made a really... it took me forever. I said, let's look at one autopsy and let's see what it takes to read the kind of comments you're making. I don't know if he was mad at me at the end or whatever, but it was really important for me to do that for those that are listening, and to see what critical and formal thinking is before you make a decision about anything. And you caught all of that.
Oh, 100%, Dr. B, 100%. And because we've had, so many of our athletes who are in active recovery, because like we say, our group is Addict II Athlete. It's just another modality to get health and get yourself on track and start moving. So I think in addiction recovery, you got to move. I sent that to a lot of the athletes that we train, and they're like, okay, I get it. And they all picked that up. Like, it was awesome because so many of them used it, but they've had horrible issues with it. And it's like, the tolerance level goes up fast. And then when they quit, it's horrible. And so I'm like, I can understand how it could be for some people, but not this population. And I love the fact that you were saying, look, you're not even able to classify it. And I think that happens so much with our people that we work with, especially newly in recovery. They'll take anything if it can get them past that hard part. And I'm like, I love the fact that you didn't allow the tsunami of like a recited, like poem to overtake you and just to stop you in your tracks. I love the fact that you took it slow. And that's why one of the reasons I was so excited to talk to you is because I know that when I ask you these questions, you'll give me a real answer. So important.
I appreciate that. And I'm actually humbled by the fact that you see what I'm doing. I always wonder if people are catching it, because I'm trying to change and realign the way people think about things on the bigger thing. And you're nailing it. It's kind of exciting.
No, I do. I appreciate it. And the hour's gone by super fast, but I'd love that if this opportunity comes up again to chat with you again, because listeners, you've been well fed. Dr. B, how do people get in touch with you? My wife, Marissa, who has a question for you. We'll do it off the air, but we can do it on the air. Marissa wants to know if you're up to the numbers you need on TikTok yet, so that we get to know, your
we just
buddy.
Want to know what Jimmy looks like.
We gotta know what Jimmy looks like. Yeah, all Team Addict athletes waiting.
We are. What are we at? We're at 85,000. It's supposed to be 100,000. And poor Jimmy, he's getting really nervous.
I love it.
Is he good?
Yeah, he's like starting to run around, and he's kind of excited. People talk about him. And I'm thinking of how we're going to do this.
Got to be something big now.
He's so neat. And you know what's funny? A few patients come from TikTok, and they actually show up on a day when me and Jimmy have been shooting, and they see Jimmy. And I'm like, hey, you guys can't say anything. But now
that's awesome. I love it. So there's a plea right there, all you athlete listeners. Go jump on Dr. B's TikTok handle and follow him so we can meet Jimmy.
So we can see who Jimmy is.
We're getting there, Marissa. We're almost there, and you guys will see him, and we'll tell a little bit about him. The YouTube channel, that's a nonprofit endeavor. I'm trying to do more and more, at least 3 times a week. One of my shortcomings on that, it was strictly started for, and I'll end this right now, it was strictly started for patient education, and about 15 months ago, and it just went crazy. We're getting over 40,000 views a month now.
I love it.
The problem with it is, believe it or not, or maybe you can when you see it, I haven't ever prepared for one talk on there. Everything is off the cuff.
I love it.
I told Jimmy and Austin, I'm like, look, I need to prepare and be more formal. We're getting a lot of viewers. So goal is to grow that. And it's strictly for education of everybody. And I want to move to the greater social stuff and bring some people on. Maybe we'll bring you on at some point here.
Yeah.
But this was fantastic. You guys are amazing. I'm so
absolutely
surprised.
We've been well fed, and so listeners, listen to what Dr. B is talking about. Jump on the TikTok. We'll put links in the podcast to get in connection with all these guys. And until next time, athletes, go turn your mess into a message.